All right, any questions before I get started? I'm going to go ahead and get working to finish endo and get into OB GYN, and again, hopefully finish on time for all the material we shall see. Let's get started. Any questions though at all? You guys feel pretty comfortable on the diabetes stuff so far? Assuming you guys are all experts at it now. Get dose insulin like a boss, right? We'll see. Anyway, so to finish up the endo section, I want to talk a little bit about thyroid pharmacology. Again, we can have issues of the thyroid secreting too much, too little, right? What are some effects from, say, hyperthyroidism that you would see? Palpitations, sweating, weight loss, right? In this hypermetabolic sort of state, right? And then with hypothyroidism, you get the opposite, right? Low energy, you're sluggish, weight gain, right? So again, super important just in terms of just overall metabolism within the body. We want to make sure we keep things in check, right? So we need to have things that can help to supplement extra thyroid hormone if we need it, and things that can help to decrease the activity of the thyroid if we need it as well, right? So I'll have different options that can help out with that. And again, it could be several different issues here. It could be the thyroid either producing or not producing enough. It could be an issue with the pituitary. It could be an issue with the hypothalamus, right? And again, ultimately it doesn't really matter because we can get down to the level of the thyroid and actually affect it directly right there, as we'll see in just a little bit. Again, this is still that same negative feedback loop you see with lots of other things. We'll talk about this feedback loop as well when we get into the OB GYN section, because this is really important for FH, LSH, and all those good hormones, estrogen, progesterone, etc. But you guys are very familiar with this. No need to belabor these points here, right? You guys are familiar with negative feedback loops and all that. Good. So what actually happens with the production of thyroid hormone? When I say thyroid hormone, I'll say things like thyroxine. Do we know another name for that? Maybe an abbreviation. Okay, so I heard T4 and I heard T3. Which one is more active? T3 is more active, right? So remember, T3 is the actual active component. T4 has some activity, but not nearly as much. And that is going to be important when we talk about our medications, right? Because we need to know what we're actually giving our patients when we're giving them thyroid supplements, right? As we'll see. So again, getting into what's actually happening here, what ion is super important for producing T3, T4? Iodine, right? So iodine is going to come into the thyroid cells. You're going to see it has this process where it ends up getting trapped here. There's this peroxidase that occurs that affects it, and so this is where you get the iodide. You're going to find it undergoes this process called organification. Basically, you're just attaching a tyrosine onto that. So when you say like T3, T4, that's where that tyrosine is coming from. That T is the tyrosine there. It's going to become one of two molecules. It could be a monoiodotyrosine, which is basically a tyrosine with just one iodine on it, or it could be a diiodotyrosine. That's important because when you're actually slapping them together, that's where you get your T3 and your T4. T3 just has 3 iodines on it. T4 has 4, right? And again, both of those are going to be produced when the thyroid is then going to be attached to thyroglobulin, which is going to be kind of a carrier protein for it. It gets released out into the body, and it can travel out and do whatever it needs to do. So how does the T3 and T4 actually affect the cells, though? Well, how does it affect the metabolism? Well, just like any hormone, right? So again, just like corticosteroids, just like androgens, just like progesterone, just like estrogen, it gets down to the level of the nucleus, right? So again, this is why when these medications, when you're administering them for someone with hypothyroidism, are they super quick, super fast to work? No, they take time, right? They take at least like a week or so before you really start to see really any big changes because they're affecting the nucleus. They have to get down to the level of transcription of those genes from the DNA to actually make a difference there. So because of that, these are not very fast-acting medications. If I were to say give you supplementation of T3 or T4, it takes time for it to really kick in. Okay, so that's one of the big things you're going to note there. And it makes sense when you think about how often you're monitoring. And what lab values are you usually monitoring when checking someone's thyroid? TSH, which TSH tells you what? Right, tells you what the pituitary is secreting, and that's usually high in cases of hypothyroidism, right? Because again, that negative feedback loop isn't being suppressed, so you get high levels of TSH. What else are you checking? Right, T3, T4 levels as well. That's telling you what the actual thyroid is producing itself, right? So those are low, we can supplement those, etc. But again, when you're checking things like TSH, it takes time for that to respond, which is why you don't say give someone a week's worth of thyroid hormone, have them come back and check it again. It's going to take much more time than that, usually like a month, 6 weeks, something like that, before you're really going to see those big effects on things like TSH, etc. Okay. No, here as well. There's going to be a couple of different medications that can actually help to inhibit the conversion from T4 to T3. That'll be important in cases like thyroid toxicosis, thyroid storm, right? Thyroid storm sounds like a pretty kind of cool disease state, but it's actually not fun, right? What happens in thyroid storm? Too much thyroid hormone, too much T3. Very severe effects, right? You get that hyperthermia, you get the palpitations, you know, you get all of that. You got to be careful with that. So anyway, and again, I always get it screwed up between iodine and iodide. I'm not gonna harm you too much if you get it screwed up too. But anyway, so typically you have this iodide trapping, right? So again, what happens is you're going to have iodide is actually what's coming in through your diet or whatever, and that's going to get converted over to iodine. That's what gets actually trapped within the cell. That's what gets slapped on with the tyrosine and the thyroglobulin. That's what eventually forms into T3 and T form there, right? So again, either the MIT or the DIT get formed there. And then this is important to note as well that you need iodine to actually support formulation of thyroid hormone, but too much iodide does what? Will actually suppress it. You can actually find that having too much iodide around is a good way to suppress the activity of the thyroid and producing more thyroid hormone, right?
Why they do that radioactive iodine?
Well, that's interesting, right? So if I were to give you radioactive iodide, what is your thyroid going to do with that? It's going to absorb it. It's going to say, let me take all that up, right? You don't really need a lot of iodide elsewhere in the body necessarily, but the thyroid's a big place where it needs it. It's going to take it all up. So if I have radioactive iodide that's sitting there emitting all those radioactive waves, what does that do? Kills the cells off, right? So if I needed to do that, if you had cancer, if I wanted to preferentially kill the thyroid, I can give you radioactive iodide, and actually that will have preferential uptake there, and it will kill off all those cells, and then presumably you don't have cancer anymore, right?
Is that why like amiodarone causes hypothyroidism? Because it's more iodine or
no, because it can actually cause hyperthyroidism too, right? So again, all it has to do with amiodarone has some iodide in it, and so it can either stimulate or in high levels can end up inhibiting it. So it's kind of an either or sort of thing there. So it's not necessarily the case. What's interesting though, so let's imagine that you were, say we're living in a world where tensions are high between countries, and let's say something happens, say there's a tweet that went out that instigated World War III. And let's say a nuclear bomb went off somewhere in our vicinity. Let's say we survive the nuclear blast, right? What's one of the big concerns of living after a nuclear bomb? You have to worry about radiation, right? Specifically, you have to worry about some of the radioactive isotopes that are formed in the aftermath of a nuclear blast. One of those is iodide. You have radioactive iodide. You have to worry about it. You can breathe it in. You can just be exposed to it, right? So actually, you have to worry about that because one of the big concerns of surviving that nuclear blast is the hypothyroidism, because you're going to uptake that radioactive iodide. It's going to get trapped in your thyroid gland. It's going to kill off all the cells. Okay, so they actually recommend doing it if you ever have like a bug out bag, right? So if you're like one of those doomsday preppers, you probably have some potassium iodide included in your stuff. Not only is it a great antiseptic if you were to say get a wound or something, but you can actually, if you have a high supply of naturally occurring non-radioactive iodide, that can hopefully help to suppress the thyroid gland. So that way, if you're exposed to radioactive stuff, it doesn't get uptaken, right? Your thyroid gland says, hey, I have too much already. I don't need any more of this stuff. You'll just process it out. Again, little known fact. Hopefully, you'll never need to use that. But I had a pathophys teacher that taught us that in class, and I was like, why in the world do we ever need to know this? But it actually helps to make good sense of the effects of iodide on the thyroid gland, both in stimulating and also inhibiting it as well. Okay. Anyway, bit of a tangent there, but as I mentioned, it can either form T3 or T4, right, depending on how they get slapped together. If you have two diiodotyrosenes put together, you get T4. If you have a 1 and a 2 put together, you get T3, right? It's just simple math there. And we mentioned T3 is the more active form, okay? And then once that gets released into the bloodstream, T4 is still present, right? You can still measure that, but that's eventually going to get converted over to T3. And again, as I mentioned, that is the active form there. And again, when we see that, we're going to find that when you have this deiodination, right? So when you are going to take away one of those iodides from T4, there's two different molecules you can actually form there. There's T3, and then there's a reverse T3. Basically, you take off the wrong iodide off that molecule, and it's not really that effective there. So if you ever hear reverse T3, that's not the active form. Regular T3 is what we're looking for. I'll show you a picture of that in just a second here, right? Our T3, that reverse T3, is inactive. Here's what this looks like. So here's like a T4, right? So notice 4 iodine molecules on the, atoms on there. If you were to take that off, this is normal T3. If you take it off on the wrong spot, that's reverse T3. It doesn't have the same activity.
When we order a T3, does it always include the reverse T3 as well?
You know, that's a good question. I have no idea. I don't know if the assay cross-reacts where it'll actually pick that up or not.
We usually use T4, so that would make sense why you stick with T4.
Yeah, and if you had someone you're suspecting of having hyperthyroidism, you can check a T3 as well to see if that is what's causing their symptoms, right? So, but yeah, I don't know if that actually will cross-react with the assay or not. It's a very good question because we can detect the difference between T3 and T4, right? So, I don't know. If you talk to a lab tech person, maybe they'll be able to tell you more information on that. Again, I don't have all the answers, unfortunately. But looking at our actual therapeutic options here, so how can we replace the thyroid hormone? Say we're not producing enough of ourselves, right? So say you have thyroidectomy because you have thyroid cancer. Let's say you have hypothyroidism just naturally. Okay, let's see what we can do for that. So we can either give T4 or we can actually give T3. More common than not, we're actually going to give T4, right? Again, the thyroid gland is a very slow-acting sort of endocrine sort of organ, so it's okay if we use slow-acting sort of medications here, right? We can use things that are faster-acting if we need to, but most of the time we're going to give just regular old T4, and that's where we get into our Synthroid or levothyroxine, right? This is the mainstay of therapy for hypothyroidism. If your thyroid gland is not producing enough of itself, we're going to replace it with T4, okay? In the body, it will naturally get converted over to T3, and it has its normal actions in the body, just like your T3 that you produce anyway. Be aware, though, right? So there's several drug-food interactions, drug-drug interactions. This thing likes to bind up other stuff, and again, if it gets bound up in the GI tract, is it going to get absorbed? No, right? So you have to do have to be careful with that. And separating all these things out, right? So actually, just a good tangent here. We did our speech language pathology program over at Nova. They actually host this Parkinson's support group sort of thing where they meet, once a month and have different topics. And so some of our students had talked on Parkinson's medications, right? And it was very interesting talking to them because you have these older individuals with Parkinson's, right? We already know what's the mainstay of therapy for Parkinson's. Yeah, levodopa, carbidopa, right? But again, they have other comorbid conditions as well. So again, we're talking about, well, I got to separate all my stuff out. My Synthroid I have to take at this time, and then I have to take my Cinemet at this time. And then, do you remember the big dietary interaction with protein, right? And so she's talking about, I got to make sure I don't eat my eggs too close to my Cinemet because then it doesn't work as well. And then all of a sudden I have trouble breathing. All these things. It was really, really cool getting to see how these implications or what implications these have on actual patients' lives and actually how it's affecting their quality of life, right? So again, little things to keep in mind. This stuff, I mention it does actually happen in real life, right? That's why I mention it, right? Anyway, so just note that this is the big thing, is that T4 is the main thing we're going to be administering. Levothyroxine, Synthroid is the main brand name. This actually used to be on what we call a negative formulary, where in the practice of pharmacy, if we have both a brand name and a generic available, which one's cheaper? Generics are cheaper, right? So again, and by law, the pharmacist has the ability to, if you write for, say, brand name, say you write for Celebrex, right? And I have generic celecoxib on the as part of the service to the patient, right? We want to give them the cheaper alternatives because we know it works just as well, right? Generics have to be shown to be just as bioavailable and all that good stuff. This is one of those things where in Florida there's actually a negative formulary where you cannot switch out. If you write for brand Synthroid, for a long time we could not switch out for the generic because there's enough difference in activity to where someone who maybe had a pretty good level on their normal Synthroid, if we switch it out for the generic, it would actually cause either hypo or hyperthyroidism, depending on how the generic was acting. I think it recently has been taken off, but just know that in some cases, if you write for a brand name, we actually have to fill it with the brand name in some rare cases.
So, but you say you don't know if it's still like that. So
I think it recently has been taken off. Again, it's more like a retail pharmacy thing, so I don't get to interact with it as much.
I know the doctor that I used to work with, she would write like brand name necessary.
Right, and remember we talked about that before. If you want to have the brand name, you have to be very specific about that and be dispensed as written, right?
Oh, okay.
Our dispense is written, we have to fill it exactly how you wrote for it, right? So we had to do brand if that's what you write for. And that's the reason why, is because there was enough variability there that they felt that it was inappropriate to switch out for a generic formulation. Now, if you have a patient who's good on the generic, just keep them with it, right? There's no reason to change it necessarily, because what are you titrating to? How do you decide if your dose is too big or too little? Follow the TSH, right? You're going to be following those things to make sure that that gets suppressed effectively, to showing that negative feedback loop is in play, right? So again, just normally keep things pretty similar. If they're on Synthroid and it's working for them, just keep on Synthroid for the most part. That's going to be better overall. Now, what else could we give? We could also give the active form, the T3. Now, in terms of onset of action, which one do you think would be faster? In the T3, right? So again, you have this liothyronine, which is given occasionally. I've honestly never seen it given in person. But it is out there. It is something you may potentially be giving there. There are parenteral forms of thyroid hormone that's actually available. It's used exceedingly rarely. The only one I've ever really seen is levothyroxine given IV. The only case I'd ever see that being used is actually in the case of patients who are going to be organ donors. So if you have a patient in the ICU who's declared brain dead and they need to get prepped for giving their organs to the benefit of others, we have a company that comes in called TransLife. You might see them occasionally on your rotations. They'll come in and they actually take over all care of the patient. They'll have a doctor there on the phone with, and they have to do things like help to replace all the hormones that their body's not producing anymore. So they're giving them insulin, they're giving them corticosteroids, they're giving them levothyroxine, all these different things to try to make sure the patient stays stable enough so they can go to surgery, harvest all the organs, and then be done with it, right? So you may see it occasionally, especially in like ICUs and things like that. Anyway, T3 also is more expensive, and again, we don't get that much additional benefit out of it, and this is not something we need to correct like right now, right? So that's why T4 is generally the thing you're going to get. There's Litrix, which is a combination of T4 and T3. It tries to mimic more naturally what your body is kind of at balance what it's producing, but again, we don't know it's necessarily that much more effective, so more expensive in most cases there. So again, when are we going to use this? In cases where you have hypothyroidism, right? Either clinically, you're following the labs, you're looking at TSH, free T3, all those sorts of things to make sure that you're getting those levels back up. Normally, T3 should be going up, TSH should be going down as you start to supplement that. Okay. So, and again, once they actually get into the cell, that's when they're going to start to interact with those nuclear receptors to start to change things like gene transcription, start to produce new proteins, things like that, in order to help to increase metabolism in the body kind of overall, more holistically. Now we have some anti-thyroid drugs as well, which is important. If we have drugs to treat hypothyroidism, we need drugs to treat hyperthyroidism. And so this is where we have a few different agents that are used here. These are going to be your thioamides as a kind of the class here. And so the two drugs that fit into this are propylthiouracil, which is commonly abbreviated PTU, and then you have methimazole, or Tapazole is the brand name for that. These are very old drugs. They've been around for a good long time. People are mostly pretty comfortable with using these. And so for most part, you're going to see these can be used interchangeably in a lot of cases. You won't see too many patients actually needing this, but there are a few that are out there. Pretty well tolerated. There are some rare cases of agranulocytosis, and when that occurs, what do you have to worry about? For granulocytes? Infection, right? So again, rare things you have to worry about, but it can occur in some cases there. And now what they're going to do is actually to interfere with the oxidation of the iodide, so it can prevent the conversion from iodide to iodine, so you can't use what's actually there, right? And so by doing that, you're going to have an inhibition of the formation of the actual T3 and the T4 there. Okay, so that's the main thing we're using for. And where we would use this would be in cases of hyperthyroidism, usually in things like Graves' disease. And again, think about this. If you have a patient who is having active thyrotoxicosis, right, so they're actively very symptomatic from their hyperthyroidism, maybe in their thyroid storm, is this going to be good for treating those acute symptoms? No, right, because they only help to prevent the production of new thyroid hormone. Doesn't do anything what's actually there. Just like when we talk about things like anticoagulants, right? Remember we talked about warfarin, how initially warfarin doesn't have good anticoagulant effect, takes a few days. You need things like bridging therapy. This is a similar kind of thing. This doesn't do anything to the active T3 that's already produced in the body. Okay, it just prevents the production of new T3 going forward, new T4. But again, we will use this either to treat those cases of more kind of long-standing hyperthyroidism, or in some cases we'll use it to try to shrink the thyroid gland. And again, if it's not producing thyroid hormone, it's going to start to atrophy, and by doing that, it makes it a little bit easier to surgerize, so to speak, and get it out of there, right? So you cut it out. So anyway, so those are the main drugs you're going to use for that. There's some other things we might use occasionally. For instance, if you have someone with thyrotoxicosis or thyroid storm, sometimes we'll actually give propranolol for that, and the reason why we do that is, one, it helps to block some of the effects like the palpitations, sweating, etc., but also actually helps to prevent conversion of T4 to T3. It's actually a side benefit of propranolol.
That one that was natural for hypo, is that the same thing as armor thyroid and West thyroid?
Armor thyroid goes back to where it's actually where they get it from.
It's like natural, like
from pork, yeah. Actually pork-based thyroid hormone rather than like synthetic. I've seen very few patients on armor thyroid specifically. Again, I'd have to double check to make sure that's actually the mix of T4 and T3. I believe it is, but
I think it is, and that's because the doctor that I worked for, she had a lot of like naturalistic patients, so they would want to take something natural like that. And the reason why endocrinologists don't like it is because they can't monitor T3, T4, like because it has both. And then,
right.
And then they have this other theory, like what if the pig was hypothyroid?
What if the pig was hypothyroid?
Yeah.
I don't know.
Yeah.
I don't know the incidence of hypothyroidism in pigs.
Me neither.
See some pigs just kind of sitting around, just kind of just laying them out.
Yeah.
I don't know.
Apparently that was their reason why not prescribing it.
Mm-hmm. And weight gain in a pig should be good, right? It's more bacon.
Huh?
Weight gain in a pig should be good, right? It's more bacon.
Yeah.
Anyway. Yeah, so that is a quote-unquote more natural form, but again, some patients may be more likely to use that. They may be more comfortable. Some people are going to like, I can't receive any pork products, right? It's a religious concern as well, so things to consider. Okay. All right, so no other questions on that. I'm going to move forward, and let's start talking about the OB GYN stuff. Okay, so getting into pregnancy and lactation first. I guess like if you're going for the chicken or the egg, we're going to start with the chicken with the egg inside. Starting with that first, right? Anyway, so let's look at fetal development, what's actually happening here. So again, we have 3 trimesters, right? Makes sense. 3 try. Which one do you think is most critical in terms of drug exposure and possible negative outcomes on the fetus? The first trimester, right? That's where we have all the organogenesis, where we have all the actual producing of the organs and whatnot. The second and third trimester, you're seeing more kind of maturation, right? And so in those cases, you're going to find that drug exposure may or may not have as much effect there as we would see on organogenesis, right? Now, again, when do people find out they're pregnant? Like right away? They have this big light that shines down on them and says, guess what, you're pregnant. It just happened. No, oftentimes they can go several weeks, several months before they actually find out, right? Because of that, you may find that people have drug exposure that they are unaware of is affecting their fetus. This is just a thing we know. It's just something you need to be aware of. And if you think back to things like we talked about with like seizure medication, we talked about valproic acid. What can that cause? Neurotic defects, right? And that makes sense because it affects when that actual fetus is developing, right? And you're actually forming that neural tube. If you have that valproic on board and you don't know you're pregnant, it can be an issue, right? And again, what else do we use valproic acid for? Seizures and what else? Bipolar disorder, right? And what do we say about bipolar disorder patients? They're in those manic phases. Are they always like taking the best precautions on things? Not necessarily, right? They may have more risky behavior. They may not use protection. They may get pregnant, right? So these are things to consider there. That's why we like for some of those high-risk patients. That's why we like some forms of birth control that are going to be, you don't have to worry about compliance. We'll talk about those a little bit later. But again, that first trimester really is going to be the most critical stage. And again, this is the most fraught one because we don't always know when we're pregnant. Right? So looking at the effects of drugs, some of it can actually be dependent on which trimester you're in. So for instance, you may find that certain drugs may be okay during certain trimesters and not be okay in other trimesters. As an example, things like NSAIDs. NSAIDs are good. They're fine to use in the first and second trimester. In the third trimester, they become we call category D, right? And are D's good on your test? No, right? These are not good for your drugs either, right? So again, this is one of the cases there where category D, not great in the third trimester, and it's actually having to do with the effects it has on the fetal cardiovascular system, right? You guys are familiar with the PDA, not public displays of affection, right? But patent ductus arteriosus. It's one of those cases there where when you have, and I'm not going to get into the nitty gritty of fetal blood flow, but you need to have certain flow to occur when the baby's not breathing on their own, right? And so if you were to close that prematurely, because again, what's normally keeping that open? Anyone know? Prostaglandins normally keeps that open. So if I were to say give something that decreases prostaglandins, that's going to close prematurely. That's bad, right? And in fact, when you have kids that are born severely premature and you still need to have that open, we'll actually give them prostaglandins. We'll give them alprostadil as a drug we'll give them. Or in some cases, once they're born and we're like, well, we want this thing to close, and it's not closing on its own, either do surgery or you actually give an NSAID. Yeah, we'll actually give ibuprofen or indomethacin, and I'll actually close that up for you. Anyway, but just goes to show you that depending on the trimester, you may find that drugs are going to be either okay to give or they're not okay to give, as the case may be. Some of it is determined on the route of administration, right? Obviously, the more bioavailable the drug is, if I give it IV, the more exposure I'm going to have. The dose, the duration, all is going to play a role here, right? So again, if you have 1 drink of alcohol in the very early stage of pregnancies versus if I were to drink every single day throughout the pregnancy, that can have a big effect, right? So you're going to find that the dose and the duration can be playing a role here as well, okay? And again, it can lead anywhere from the complete destruction of the fetus, right? So it's just not viable, all the way to, growth retardation, structural abnormalities, all kinds of things can occur. So it kind of runs the entire gamut here. So when you're looking at drugs, they talk about pregnancy categories, and we're kind of moving away from that, and I'll talk about why that is in just a moment here. But we have 5 different categories, right? So you have A, B, C, D, and X, right? So someone must have not taken their lessons from kindergarten, didn't learn the ABCs. But so we have A, B, C, D, and X, right? So which one sounds like the best one to give? A, just like on your test. Like if it has an A rating, that's usually pretty good, right? That basically means that we have studies to show that there is, we've given this to thousands of women who are pregnant. We've seen no deleterious consequences on the fetus. Okay, so if someone has an A rating, I would feel very comfortable giving it to a pregnant patient, right? And you can always think back to it, like if my wife was pregnant, would I want them to receive this drug? That's how I kind of think about it. I would be very comfortable with her receiving an A-rated drug, very safe, right? A B kind of gets it a little bit. Oh, yes, sir. Not necessarily, right? So you're going to find that, especially when we talk about like NSAIDs, it's going to be like, say, a B through 1 and 2, and then the third trimester becomes a D, right? So again, it can be very dependent on the actual drug in the trimester specifically. When you get into B, that's when we start getting into a little bit more of a gray area. Generally, still pretty good. I would still give this to a pregnant patient. But you start to maybe either get into cases where there's animal studies that maybe show some harm to the fetus. But again, we are not mice for the most part. And so we have human studies that show there's no danger, right? So again, usually animal data is good for extrapolation, but it's not one-to-one, obviously. And so there's studies that show that humans have received this, no big problems with this one. So B ratings are generally pretty good as well. Now again, what's the problem with doing studies in pregnant women? Well, generally you can't really do it, right? Because it's not very ethical to say, well, I'm going to have 100 pregnant women, I'm going to give 50 of you this drug and 50 of you nothing and see what happens to your babies. Not great, right? So from an ethical standpoint, you can't really do that. A lot of this is going to either be voluntary reporting of adverse effects that occur. A lot of it could be retrospective studies and things like that. So again, this data is not always going to be foolproof, right? And a lot of these drugs we've had around for 100+ years or something, and we just say, well, we have a lot of evidence with it. We don't have studies necessary to show us that it's safe, but we think it's pretty safe, right? Like think about Tylenol. All right, Tylenol's been around forever. Probably pretty safe, right? Because otherwise we would have detected something based off the millions of people who have received it. Anyway, then you get into category C. And this is where the pregnancy categories become pretty fraught and not super clinically useful. So does everyone have like a drawer probably at their house where like all the junk that gets put into it, right? All your iPhone 2s and 3s and all other electronics you're not really, you need to throw away, but you're not really going to throw away ever. It's going to stay with you for every move from here until that nuclear blast happens. That is what the category C is, right? Everything gets kind of dumped into there if we're not really sure, right? So either there's maybe some animal studies maybe show harm, we don't have good human information to show, and the vast majority of drugs get put into this category. And so it's not super useful because, again, I don't know if it's safe to give or not safe to give based off of just a single letter rating of that. So because of that, C drugs need to be a little bit more careful, right? D gets into the category of where we know there's harm to the fetus. We know there's going to be danger to the fetus if we give this drug. However, there could be cases where giving it to the mom is the benefit that outweighs that risk. Okay, and again, if you get into situations where if the mom dies, guess who else is going to die? The fetus, right? So in those cases, there may be some situations where it is okay to administer a drug to that patient, even though we know there's potential harm. And then X is going to be what? There's no situation where the benefit is going to outweigh the risk. I always think about things like Accutane for this one. Like, mom, I'm sorry, you may have some acne for the pregnancy, but it's better than having, your fetus not make it, right? So again, these are cases there where there's no clinical benefit to administering this. You're just going to be absolutely contraindicated.
You know how NSAIDs are D? Now, do they change the class for depending on the trimester?
Yeah, right. So again, it can be very specific to the trimester. And if you look this up, and I urge you to go check out some drugs on Lexicomp or something and see what categories they fall into. So for instance, like an NSAID will be B in 1 and 2, first and second trimester, and third trimester it'll be a D, right? Because we know that at that point, that's where that fetal cardiovascular development is really kind of more prone to effects from prostaglandins and whatnot, and that's where it becomes much more dangerous to give an NSAID. Okay, so in some cases, not all cases, most of the time they're just going to get like just a one lump rating. Most of the time it's going to be C for the most part, right? For a lot of drugs. So anyway, so again, not super useful here because again, as a clinician, if you told me, hey, 90% of the drugs out there are category C, well, I don't know if it's safe for my patient or not, right? You have no idea, right? So what do you need to do? You gotta look it up. You gotta dig deeper, right? So you need to find the information that actually says, well, what info do we have, right? Because you want to be more educated when you make a decision for your patient, right? Because it's not just one patient you're making a decision for; it's 2, right? So, or it could be more than that. It could be 3, it could be 4. It's very scary, but it could be, right? Anyway. So nowadays we're starting to move a little bit more into more useful information, right? So instead of just having the old nomenclature, just putting C on all these new drugs that are coming out here, instead we're going to be listing out the actual information. It says like, okay, well, here's what happened in these pregnant patients who received this. Here's what happened to their babies, right? If you're lactating, here's what happened to the babies that received this while the patient was lactating, right? So that's becoming more useful. However, it requires you to do a little bit more reading, right? As a clinician, it's really easy if you can just say, well, it's a B, it's safe to give. It's a D, I'm not going to give it, right? Just like that's why we like scores and things like, okay, your CHAD score, blah. Okay, I'm going to do this, right? We like things to be very clear cut. this isn't as clear cut, but it's still much more useful when you're dealing with these very high risk sort of patients here. Just to give you an example, for warfarin, warfarin is a category X drug in almost all circumstances. However, if you notice here, it's a D in the case of women with mechanical heart valves. So there's a clinical situation where if a woman has a mechanical heart valve, they are such in a prothrombotic state, or they're at risk for thrombosis, that it makes sense that there is some potential benefit of giving warfarin. There's a benefit to the mom that outweighs the risk to the fetus, right? In every other circumstance, there's no reason to give warfarin. We can give heparin, right? We'll talk about things we can use for pregnant patients later, but we can give other safer drugs. However, if you didn't have that information, you can actually read through it and actually see, okay, well, what happens here? Okay, warfarin crosses the placenta, right? We see these concentrations that happen in the fetus. We know what happens based off of all these studies. It's more work on you, however, you got to do a little bit of work in order to make sure you're doing right by your patient, right? I'll give an example of something like Zofran, right? Nausea, vomiting, very common thing we see in a lot of pregnant patients. This one's a pregnancy category B. However, it wasn't a B for a long time because it's a relatively new drug. We didn't have a lot of evidence for its use. So before that, we actually had to go and look to see what was going on here, right? So looking to see, were there any teratogenic effects, right? Okay, none observed in animal reproduction studies. Okay, that's a point. It may not be super relevant to my patient, right? I'm a vet. But there's good information to start with, and then we can see, okay, what happens? Does it cross the placenta? Does it actually have levels that achieve there? What does it do to the heart, etc.? By looking at all this information, we can make a more educated decision on what we're going to do for our patient, right? But again, clinicians always want to go back to, all right, it's a B, good to give, good to go, right? Is it an A? Great, I can definitely give that. However, it may not always be the case there, okay? So, obviously, what's the best drug for a pregnant patient? No drug, right? So if we can limit drug exposure, that's always going to be the best thing for our patients. However, you have to consider, just because you get pregnant doesn't mean that's your only disease state now, right? You have to consider, what were they having going on before? Are they bipolar? Do they have depression? Do they have diabetes? Do they have heart failure? Right? All these things you have to consider when they are now pregnant, right? So again, we're going to find some medications are absolutely just never ever going to use. Some medications are okay to use. So imagine if you had a patient who had hypertension and they become pregnant, and they'll say they were on an ACE inhibitor before they got pregnant. Yeah, so certainly you're concerned about things like preeclampsia, but can you be on an ACE inhibitor and be pregnant? Ooh, that's a absolutely. Yeah, so we'll talk about alternatives, right? So again, you have to consider what were they on before. Now, because we know that not all women just know immediately, some light just doesn't go off, says like, guess what, you're pregnant now. You have to consider things like, well, are they planning to get pregnant? Maybe you want to switch their medications over beforehand, right? Maybe you want to switch them over to something that's going to be a little bit safer in the off chance that they do get pregnant, right? So again, these are things you have to consider there, and again, these are good conversations to have with your patient. So obviously, if you can try to identify medication use prior to conception, it's always going to be good. Not only prescription medications, but what else? Over-the-counter stuff, herbal stuff. What else? Illegal stuff, right? Illicit stuff. We're going to be taking home remedies, all these things, right? You have to consider, because again, if mom is addicted to a substance, and the baby's exposed to it the entire pregnancy, that baby's going to come out addicted as well, right? And you have to deal with that. We see a lot of neonatal abstinence syndrome because, again, being at Nemours, we don't birth any children there, right? Because we're not a women's hospital, but we have a lot of babies that get transferred into us, and we get we're more predisposed to sick babies because, again, they can't handle them at other hospitals that get transferred to us. So we see a lot of the sick babies, and guess what? A lot of them have neonatal abstinence syndrome. It's a big thing you have to worry about in these patients here, right? Because moms have been using drugs throughout the entire pregnancy, right? Because, again, addiction is a nasty thing. If we can, try to eliminate non-essential medications. That's always going to be beneficial. Try to discourage self-medication, right? Talk about, okay, well, if you have pain, this is the medication you should use, right? Don't use this one. Use this one instead. Have that conversation beforehand, and try to minimize that exposure as best you can, right? So if you can either do that with the dosage, maybe decreasing doses, maybe using different routes of administration, etc., all that can be useful to try to limit exposure, okay? So let's look at some of the common pregnancy-induced conditions that occur here. We're going to talk about things like nausea, vomiting, heartburn, constipation, kind of all the GI stuff we'll talk about. We've already covered GI meds. So again, this is all going to be reviewed for the most part. We're going to talk about which drugs are specifically good for pregnant patients. We'll talk about diabetes, hypertension, and some coagulation disorders as well, right? So these are kind of the common things you're going to run into. So looking at nausea, vomiting. Again, what happens to a pregnant woman's GI tract and just overall GI health when they get pregnant? Goes down the drain, right? It's not great, right? Their sense of smell kind of changes. Like certain things will kind of trigger them off before. Some people really don't like the smell of their husbands anymore. I fortunately don't have to deal with that, but that is a concern, right? Certain things are just like, this just smells awful. So they're much more sensitive to that. You're going to find that when they have all this extra blood volume, they have all this extra weight from this baby that's pushing pressure on their diaphragm, it puts all the pressure on the stomach. Like, it's awful. Being pregnant is the worst. I'm so glad I don't have to do it, right? It's a beautiful process. It's great when you're done. Except when your baby wakes up and you have to take her to the ER in the middle of the night because she's croupy, but whatever. She's fine. She got a dose of Decadron. She's good to go. But regardless, though, anyway, so getting into it. So let's look at some things we can do for these patients. Obviously, we can do dietary changes like smaller, more frequent meals. Certain things to trigger them. Try to get away from those. Those are things you can try to shoot for, right? So again, I had to make dietary changes myself. My wife was pregnant because some of the food that I ate was like really smelly to her, and so I'd say, well, I guess I can't eat this for 9-10 months, right? Anyway, but other things you can do, right? So what are some things that are safe for pregnant women that are good from a nausea vomiting sort of standpoint here? So a couple things we can try. One is pyridoxine, right? You think like pyridoxine, how does that work as an antiemetic? I don't really know, right? It's B6, right? It's a naturally occurring vitamin here. But it's category A. It's very, very safe. And that makes sense because they probably need vitamin B6 anyway, right? So it's going to be a component of the prenatal vitamins anyway. The other thing we can do potentially is an anticholinergic, right? So we know that these are going to have good antiemetic effects by affecting the CNS here. And one we like to use is called doxylamine. And we know what category this falls into? Well, it's a category A, but category as far as like medication class. It's a first-generation antihistamine, right? So it fits in the same category as diphenhydramine, as hydroxyzine, as dimenhydrinate, all those things, right? They're anticholinergics, but they're first-generation antihistamines, okay? So by actually using the two together, they have a new drug product called Diclegis, but it's actually pretty expensive. I know one of my docs I worked with was pregnant, and they were taking Diclegis, and it was like $85 a pill. I was like, why don't I just buy it over the counter, right? Doxylamine's under the brand name Unisom over the counter, right? They use it for sleep. Vitamin B6, I said just add those two together, right? A lot cheaper, right? But sometimes I like that. Well, what's the downside of using something like doxylamine, though? It's going to make you drowsy, right? So you need to be aware of that. It could be good if they get nauseous before they go to bed and they're lying down, they're recumbent, and they have all that weight pressing up on their diaphragm. That could be okay. But if they need to go to work and be productive, maybe not so much, right? So again, be aware of that's going to make them somewhat sedated. The B6 is going to be pretty benign for the most part, right? No issues there. Yes,
can they also experience like the hyperactivity, like the other side effect of like the antihistamine?
There may be a rare person that does that, but not a common thing, right? Yeah, just like commonly you don't see that in a normal adult, so I wouldn't expect to, but you may find that one snowflake that does that, right? Again, not snowflake in a derogatory term, but someone who is unique. Other things we can try: metoclopramide, Reglan. Right, remember that has those D2 blocking effects, right? So you have to be careful of that in high doses. Promethazine is another one that we like occasionally, but again, very, very sedating. So you do have to be aware of that. Okay. Now, again, for a long time, those are the only drugs that we had. We had the most safety data associated with those. We didn't really know if Zofran was going to be a good drug to use or not. Nowadays, though, we know that Zofran is going to be a category B. We have enough evidence to say we're confident about that, and so you can use this. However, it is more expensive, so I would generally recommend most pregnant patients try the doxylamine, try the B6. If that doesn't work for them, then they can try something like a Zofran, right?
Isn't that the one that normally gives like the Zofran pump?
Zofran pump.
I know you guys have it throughout the whole pregnancy.
Perhaps.
Zofran.
I've never seen it, but yeah, that would make sense if you're having that severe nausea, vomiting all the time. Yeah, you can potentially see that. But yeah, I've never seen it in person, but yeah, perhaps. Yeah. And again, more expensive, just be aware of that. And again, when you're thinking about things like pregnancy and lactation, what are some of the things about the drugs that will affect how well it crosses over into the placenta or crosses over into the breast milk? Lipophilicity is a big one, right? So more lipophilic it is, the more likely it is to cross over. What else? The drug size, the actual molecule itself, is a very large molecule. It doesn't like to cross over. So those are things that can affect how well it either gets into the placenta or how well it gets into, for the fetal exposure, or gets into the breast milk. Those are all things we think about, and that's what affects kind of what categories it gets put into there. Again, sometimes things like breast milk actually can trap certain medications in the breast milk because of the changes in pH, right? So you can actually find that by changing the pH, you're going to cause it to be in an ionized state and prevent it from getting reabsorbed back into the mom, and so you can actually have concentration of the drug actually in the breast milk itself. You can see more drug exposure there, right? So it's some things to consider, right? Now, getting into heartburn, as I mentioned, more frequent meals, smaller meals per day. And we'll like things that actually have limited drug exposure, right? So if you think about things like, what would be good heartburn medications that may be good for a pregnant patient that really either should have limited systemic effects or are okay for systemic exposure. Tums, right? So calcium carbonate. Makes sense, right? They're producing a whole new skeleton inside of them. Makes sense. Calcium's probably an okay thing for them to receive. However, what does calcium cause? Constipation. Do pregnant women get constipated? Yep, and they get hemorrhoids to go along with it, right? So again, these are things you have to consider. Are they already constipated? Calcium is going to make that worse, right? Carafete's a good one. Again, more expensive. It's prescription only, but it's good for coating the stomach and trying to help to limit some of the effects of the stomach acids there. And again, if those other things don't work, if your antacids and your H2 blockers are not working, Carafate and your antacids are not working, that's when you can move on to the H2 blockers, right? So again, generally pretty safe. They've been around forever. We know they're probably going to be okay, and again, they're relatively cheap. So you're going to your Zantac, your Pepcid, all that kind of good stuff. And if that still fails, then you can kind of move on to the PPIs. Kind of similar to what we normally would do for heartburn. In general, these are not going to have a whole lot of concerns there. However, consider things like, what other antacids do we have at our disposal? So we say calcium carbonate. What else do we have? Aluminum hydroxide, usually found with magnesium hydroxide, right? So that's one thing you can use. That Malox or Mylanta. What else could you have? Pepto you could probably use, but again, not commonly, not super common. But again, you have to think about what's in Pepto. The salicylate, right? So you have to think about that not good in the third trimester because that has the same kind of NSAID sort of actions, right? Think about sodium bicarb, right? Sodium bicarb. Why would you want to be careful in giving sodium bicarb to a pregnant woman? Edema. What else? So again, to go along with that increased volume, what does that do to maybe like your blood pressure? Hypertension, right? And they may already have preeclampsia, right? So those are things you have to consider as well. Okay. If they have constipation, what are we going to do for them? Get more fiber in the diet, right? Again, give them the kind of a bulk forming, non-absorbable sort of fiber that can be very useful to try to get things moving along. Your Metamucils, your psyllium husk, all that kind of good stuff is totally fine. Some moderate exercise, like don't tell them to go on a marathon, but again, some moderate exercise, get walk around, can sometimes help with that. And so, like I mentioned, bulk forming agents are the drug of choice because they are not absorbed. There's no exposure to the fetus, right? We like that. Things like stool softeners can be used, like a DocuSay. That's generally going to be okay. Against the category C, we don't know if there's harm specifically, or if it is, it's extremely rare, and so that's why it's kind of a backup agent. We don't go with that first because we just don't really know, right? We don't have the studies to give us that it's probably safe, but again, we don't know. That's why it gets category C. And then we're starting to see more use of the osmotic agents, so specifically like Miralax, now that is over the counter, that's starting to become used more frequently, along with like your bulk forming agents there. So that's definitely something to consider. Typically we don't like to use your stimulant laxatives unless you really need to. Again, intermittent use is okay, not all the time, because what happens when you use stimulants all the time? You're kind of dependent on it, right? Those muscles are to atrophy that normally govern defecation, and so again, you need to have that drug around at that point. So just like using Afrin for nasal congestion, you get that rebound nasal stuffing. The same thing happens here. You get rebound constipation.
Inhibit like nutrients from getting to the baby also by always giving yourself.
Again, these are not doses such that you're going to see a lot of like inhibition of absorption of vitamins and things like that, right? So you shouldn't probably see any issues with that as long as you're getting a good healthy diet. Otherwise, they're taking the prenatals and all that. So it shouldn't be a big concern, but theoretically, you can see if someone's like maybe abusing these or something. I just don't want to gain weight while I'm pregnant. Maybe you might run into I haven't seen that, but it could potentially occur. But anyway, and you can be careful with things like mineral oil that is fat soluble that could actually adsorb some of the fat soluble vitamins like A, D, E, and K, and actually cause some issues there. So that would be a concern. As far as hemorrhoids go, the best thing you can do is avoid constipation, right? So again, it's usually we're going to find overstraining and things like that will cause the hemorrhoids to occur. If you can try to prevent that, it's always going to be good. And again, we have some good topical products we can use here. Things like hydrocortisone, again, applied topically is going to help with some of that inflammation. We have things like Tux pads, witch hazel. What does witch hazel do? Anyone know? It's considered being astringent. It's astringent. It's good for your skin. It's also good for hemorrhoids. It causes like kind of a tightening of the tissue, right? So again, it's going to tighten up and try to kind of pull that blood vessel kind of back in a little bit, right? Because that's what the hemorrhoid is, the kind of ballooning out of that blood vessel. By tightening it up, it tries to kind of pull it back in. So usually using a mixture either like phenylephrine, which is a vasoconstrictor, which is going to kind of do the same thing. Witch hazel, preparation H with the hydrocortisone, all that's going to be good there, right? Again, it's preparation H for the hydrocortisone, not because A through G failed, right? And yet, the patients having diarrhea, loperamide can be used. It's actually considered category B, even though you worry about like the opioid effects and all of that. It's not going to be an issue for the fetus. It's not going to be able to cross over because remember, there's loperamide. It works on opioid receptors in the GI tract. Why doesn't it cause euphoria in our brains? Well, it has. It's not lipophilic at all because it has that positive charge on it. Remember, we're talking about positive or permanent positive charges on molecules prevents it from crossing over. Well, if it can't cross the blood-brain barrier, guess what? It can't cross. What else it cannot cross? The placenta, right? So same kind of physiochemical properties stand in those cases, right? Okay, so getting into pregnancy-induced hypertension. So certainly you can have patients with pre-existing hypertension is a concern, or you can have patients that will develop it during the pregnancy there, right? Because if you think about it, what kind of physiologic changes are occurring in the pregnant woman in the cardiovascular system? Ton of extra volume, right? So again, it's really interesting once a woman gives birth to see the diuresis that occurs along with that. Because once the baby's born, they don't need all that extra blood volume anymore because they're not pumping blood for two. So they have a lot of diuresis. But while that volume is there, it's going to be increasing pressure. It's going to be increasing things like edema. They get a lot of swelling that occurs, especially like in the lower limbs and things like that. So again, this can contribute to the hypertension. And so we'll consider it gestational hypertension when their BP gets above 140/90. And then when they start to have that proteinuria that goes along with that, so again, the pressure's high enough where it's actually forcing the protein out through the glomerulus and it's not being reabsorbed, that's when you consider that preeclampsia, okay? And again, it's a relatively common thing, 6 to 8% of pregnancy, so you're going to run into it with some frequency. And again, once the proteinuria starts to pick up even further than that, that's where we consider more severe preeclampsia. That's where the blood pressure is like 160 over 110. Starting to really start to pick up there. And then eclampsia is where they actually develop that tonic-clonic sort of seizures. Okay. Again, that is where it becomes a medical emergency. We actually have to manage that, and we'll talk about medications we're using for that in just a second. Does anyone know what the drug of choice is for eclampsia? Seizures? Yeah, it's actually magnesium, which is not something you would intuitively think of, but we'll talk about why that is in just a minute here. So looking at the hypertension during pregnancy, some of the things we're going to look at. So one, if we can try to give them bed rest, that can be sometimes useful. However, what's the problem with laying about in the bed all day long? You have stasis, maybe contributing to some weight gain as well. But again, your blood's being more just kind of lying around there. And we know that pregnant women tend to become hypercoagulable, right? Has a lot to do with the hormonal changes that are occurring for them. So because of that, they're at risk for VTE. Not a great thing, right? So you have to kind of weigh the pluses and minuses there. Obviously, stress reduction. So just say, just calm down. It's okay. You're just pregnant, right? That works very well. I'm kidding. That doesn't work at all, right? Never tell someone stressed out just to calm down, right? Does not work. Some mild exercise, things like that can all be kind of helpful here, right? But once you actually get into the actual drug therapy here, we actually find that calcium is actually a good thing to administer here. We actually find calcium can help to reduce that relative risk of having hypertension or preeclampsia. Again, the full mechanism, not really sure, but again, this is something they probably need anyway. It's going to be in the prenatal vitamins. Again, they're growing a whole new skeleton inside of them, which sounds kind of creepy when you think about it, but that calcium is going to be needed regardless, okay? And then actually when you're getting into the treatment of eclampsia, when they actually start to have those eclamptic seizures, magnesium sulfate's the thing to use there. If you think back to it, we used magnesium before in the treatment for, say, severe asthma. Anyone remember why we used that there? It works as a muscle relaxant, right? It kind of is like a natural calcium channel blocker. It causes that smooth muscle to relax and causes bronchodilation. Same thing kind of happens here for the blood vessels. Just like when I give a big bolus of magnesium to a patient, I see their blood pressure drop. That's something you have to be concerned with when you're using it for asthma. Same thing happens here. In fact, you'll never see so much magnesium being used with such gusto as you do in pregnant patients, right? If you go to the labor or like the OB wards and things like that, they'll give magnesium 4 or 6 grams, like just bolus. I'm just like, oh gosh, that's a lot. And they're just like, oh, it's fine. They'll be great. They do totally fine, right? And so they'll get like a really big bolus and followed by continuous infusion, and that will help to maintain the blood pressure, right? And again, this is IV that they're administering. This is not something they're necessarily going to go home on. So, okay, so that's like the severe management. Well, what are they going to do, say, when they're at home, right? What are they going to do for the duration of that pregnancy if they develop, say, they're not eclamptic yet, but they're, say, having preeclampsia? We'll talk about that in a second. But 2 things you want to avoid if you have a seizing patient due to eclampsia is you do not want to use traditional anticonvulsants. Phenytoin, you don't want to use benzodiazepines. Those are category D's medications, right? So you do not want to use those because we know those cause fetal harm. So looking at the more chronic management here, this is where we're going to see a couple of drugs that are used. We used to use a drug called methyl-dopa previously. It used to be the old drug of choice, and basically what it does is it depletes catecholamines, basically kind of stimulates release of them, and will cause a depletion, and that will then overall lower the sympathetic tone, lower the blood pressure, lower the heart rate. Not used quite so much anymore. Nowadays, what we're going to be using is something like labetalol. Labetalol is a really good one as a third-generation beta blocker, right? It's good because it blocks some alpha receptors. You're going to see some vasodilation because of that. Generally going to be used for first line, right? It's good because it has oral options. There's IV options we can use as well if they come in and they're severely hypertensive. This is a really good option before you get to that magnesium you're going to be using there. Other things we can use include things like dihydropyridines, like calcium channel blockers. We'll talk about those a little bit later and what other utility they can have. And then for really rapid management, this is where things like nitroglycerin can be used, things like nitroprusside, all can be used as well. Okay, but again, those are IV agents. Those are good for like really severe hypertension. They're titratable drips you're going to be administering. Generally, women go home dealing with that chronic hypertension, labetalol is going to be the go-to. And again, if you had a patient who is looking to get pregnant who had hypertension beforehand, and they were on, say, like lisinopril, this would be something you may want to consider switching them over to a beta blocker, right, beforehand, so that way they don't have any exposure to those ACE inhibitors, because again, that renin-angiotensin system you don't want to affect in the fetus. It's very important to have that for that organogenesis. Okay. All right, any questions from the first half? The thyroid stuff, or getting into the pregnancy stuff. Again, it's a lot of the same drugs in terms of pregnancy. It's just how we're using them, which drugs we're selecting, etc. Getting to the diabetes, what do you think is going to be the drug of choice for pregnant patients with diabetes? Insulin, right? Ideally, what would it be? No drugs, right? Ideally, we'd like to do dietary modification, all of that. How do you determine if someone has gestational diabetes? OGTT, right? The original gangster tolerance test. No, oral glucose tolerance test, right? That is commonly what we do. Again, what are we testing for? We're testing to see how well their body is responding to that glucose load, to see how well they are taking that glucose, putting it into their cells versus leaving it all into the bloodstream, right? Because again, hyperglycemia is not good for the baby, it's not good for mom. You're going to find that they tend to be more likely to develop type 2 diabetes later on in life after the pregnancy. Babies may be more at risk for type 2 diabetes, etc. And again, it's relatively common, especially when you have women who tend to be may have had diabetes beforehand or had high degrees of insulin resistance beforehand. They tend to be more likely to develop this gestational diabetes already, right? And again, it's just going to be one of those natural things. Again, the physiologic changes, you tend to get more insulin resistant, right? It's just what we know is going to happen there. And so dietary modification is the biggest thing. I remember my wife was really intent on not getting gestational diabetes, and she wanted to trick the test, and so she said, I'm just not going to eat any like carbs like the week before, or like no sugary cereal, no donuts, or nothing the week before my OGTT. I'm going to trick it, and then still came back a little high. And again, it's different for every pregnancy, so you have to get it done every single pregnancy, because the first one she was totally fine, the second one she was a little more borderline, and so it can just depend, right? Sometimes they'll just the next pregnancy will be the one that kind of tips them over the scales a little bit. The drug of choice, though, is going to be insulin. Again, it's a natural product your body produces anyway, so it makes sense that it would be not going to be. Anyway, what do you call it when a drug has negative effects on the fetus? What is the term for that? Teratogenic, right? So insulin is not teratogenic because it's something we produce anyway. We know what it does there. We don't use things like sulfonylureas, because that can actually cause depletion of insulin in the fetus, which is no good. Metformin appears to lack teratogenicity and may be able to help with insulin resistance, but for the most part, most pregnant women, if they need anything, are going to be reliant on insulin. But again, if you have someone who is otherwise healthy and becomes pregnant, all of a sudden you're like, oh, now you have to start injecting yourself for the pregnancy. Like that is a hard sell, right? So that's why we like to really focus on moderate exercise, dietary modifications, etc. Okay. So thromboembolism is also a big concern here as well. I'll talk about the effects that estrogen has on clotting factors a little bit later when we get into the rest of the gynecology section here. But we do know the VTE is a higher risk for these patients. Okay. Now warfarin, as I mentioned before in that one slide, I saw it was a category X in almost all women unless you had a mechanical heart valve. So that's not going to be recommended, right? Because again, it's affecting a fat-soluble vitamin K, right? And you never want to mess with fat-soluble vitamins for fetus because they really need that for their development. So warfarin, not going to be recommended for them, right? So what can you do instead? This is where we have things like subcutaneous heparin was a drug of choice for a good long time, but it didn't have a good long half-life, so that was kind of unfavorable. Now we also have things like Lovenox, right? You have things like low molecular weight heparins have a little bit longer half-life. Now whether or not pregnant women are going to be able to use some of these newer 10A inhibitors like the Eliquis and things like that, I'm not sure. I haven't really looked into it that deeply to see if there's anyone trying to use it, but it's always hard to get a new drug approved in pregnant women, or because again it's hard to do the studies, right? You can't do the studies, you have to just use anecdotal evidence. Okay. And then typically, if they have any issues where they got a clot, typically you're going to have them on kind of long-term sort of anticoagulation to make sure they don't have any recurrent clots. And so you may see something like, maybe throughout pregnancy they'll be on the Lovenox, and then maybe 6 weeks after delivery, or at least a minimum of 3 months or so. By that point, they should be sort of back to normal levels of their hormones. They should be not at risk for clotting again, unless they had some kind of predisposing condition in the first place. So other things, treatment of acute conditions like UTIs. Even if it's asymptomatic, you always got to treat a UTI for these pregnant women, right? Because we do know there's risk for the fetus if that were to become much more of a systemic infection. This is where things like nitrofurantoin or macrobid's a good drug of choice, amoxicillin, cephalosporins, all are going to be considered category B drugs. All these are totally fine to use dependent on, what is actually growing. So you're going to do the culture anyway, but again, empiric therapy, any of these are going to be fine for those patients there, okay? As far as pain goes, what do you use for pain? Acetaminophen is always going to be the drug of choice, right? So this is one we have the most evidence with, so Tylenol is going to be fine. However, if they have a history of migraines before they got pregnant, now they're having a migraine while they're pregnant, you say, here, take some Tylenol. What are they going to say? They're going to laugh at you. They're going to be like, that's ridiculous. I'm not going to do that. Silly. But again, what were the problems with a lot of migraine medications we saw? Things like your triptans, things like your ergotamines. Couldn't use in pregnancy, right? So again, this is a tricky situation you have to deal with here. NSAIDs can be used in the first and second trimester, but because of the effects it has on that PDA, you can actually close it off prematurely, so we do not want to use it in the third trimester. Okay, so sometimes there's a little bit of intricacies here you have to consider about which trimester you're actually in and which drug you're going to use for those patients. Okay, now opioids are okay to use. It does not have any negative effects directly on the fetus. However, you have to be careful. If women are going to be on it throughout the course of pregnancy, that fetus is also going to be exposed to that for the course of the pregnancy as well. And this is where you run into problems where moms are using heroin or other opioids and the child is born, and then they have the neonatal abstinence syndrome, right? You're making them go cold turkey. And just like adult patients don't do well with cold turkey, little babies don't do it either, right? What are some problems you think you can see with patients with neonatal abstinence syndrome? Yeah, so thermoregulation is a big problem. So they can't really maintain their temperature very well. They get super fussy. They don't eat well. A lot of problems, right? So again, they're very difficult to manage. So sometimes we'll have to supplement them with things like methadone, or we'll give them things like clonidine to help deal with some of those effects. But again, opioids are okay to use in pregnant women for short-term courses, right? So again, if you have an injury, something like that, like morphine's probably going to be okay for them in the short term. Okay. Again, it becomes a D when you have really prolonged use of high doses, right?
In the migraine lecture, I probably had something like acetylcholine and topical, like Furosemide. Give that to them instead of giving them the morphine or the.
Potentially with Furosemide, like it's the studies behind it really don't show it's that much more effective than plain Tylenol in a lot of cases, right? So I probably wouldn't jump to using maybe Talbotol, but if they want to use like acetaminophen and caffeine, I'm probably okay with that, right? And again, that's why you have to really talk about self-medication and talk about over-the-counter stuff that maybe you've used beforehand. So if they use Excedrin migraine that has aspirin in it, right? So that's a concern. You have to tell them, hey, be careful with towards the third trimester here. After this date, you don't want to use this stuff anymore, right? So those are things you have to consider and make sure you're having conversations with them about it.
I was just thinking of like those who suffer from migraines and end up getting pregnant, and those are the only things that would work. So
yeah.
I was just wondering.
Yeah, I'd have to double check on the Talbotol. I don't think it has any direct teratogenic effects, but I have to double check on it. Yeah. And again, what's the ultimate question if you're not sure about anything here? Look it up. Especially with these really, really high risk patients, just look it up. Even if you're sure, if you've done it a million times, it doesn't hurt to double check yourself, right? Always look it up, right? What comes before the fall? Pride comes before the fall, right? So again, if you think you know everything, that's a good way to find out that you don't know everything. Not fault of the patient, but the actual fall of you getting in trouble for doing something you shouldn't have done, right? Look stuff up. It's a bad leading question. Anyway, so getting into mental health during pregnancy. So again, this is something we're starting to see as much more of an issue than it was before, right? So again, we as a nation, as a country, as a civilization has a hard time seeing mental health issues as anything but a stigma. You have a really negative stigma associated with it. But we do know these pregnant patients, I mean, just in general, like, just being pregnant, it's going to cause you a lot of stress, right? You're thinking about the future, like, what am I doing for this kid? Everything you put in your mouth, is it going to have a negative effect on the kid in the future? I have no idea, right? So there's a lot of stress and anxiety. There's mommy guilt. Like, mommy guilt's already a really big deal, where you think like, okay, well, I can't go back to work because if I leave my child, they're going to grow to be, they're not going to cope well with life, and they're going to be terrible. Like, there's a lot of things, right? Not all of it is necessarily rational, but it is something we know. Anxiety and stress and depression is a big, big deal here. So we do have to take care of it, right? And people have depression before they get pregnant, anxiety before they get pregnant, so we got to do something with that too, right? So, we consider this the postpartum depression, the postpartum blues that occur here. A lot of this has to do with the kind of massive changes in hormone levels that occur after the baby's born, right? Because again, your body's producing a ton of estrogen and progesterone, and all of a sudden that baby's gone. Your body says, okay, we're done. And those levels tend to drop pretty precipitously, and so that can help to precipitate some of that postpartum depression. But just in general, it may uncover depression was there beforehand, right? Depression and anxiety. And so you're going to find that by being more aware of this, we're going to be more likely to treat this. We screen for it more. We're more likely to actually be treating these patients appropriately, and we don't have things like postpartum suicide and things like that. We have to really be worried about. So what are we going to do for these patients? Well, drugs of choice are typically going to be our selective serotonin reuptake inhibitors. So SSRIs are going to be good. Again, these are nice because they're very specific in their mechanism. They only affect the serotonin reuptake receptors. They're not going to really do anything else, right? You could use things like potentially like a TCA, but we do know there's side effects associated with those, right? The anticholinergic effects may not always be beneficial for a lot of purposes. So SSRIs are generally going to be the thing to go with. Now, does that mean they're completely safe and benign? Not necessarily, right? So again, there are concerns with it. There are concerns about things like pulmonary hypertension in the fetus. There are concerns that if mom's on the SSRI all the way throughout, again, do people do well when they go cold turkey off their SSRIs? No. Does the baby do well when they go cold turkey off their SSRIs? No. So that's the thing you have to consider, right? Is the mom breastfeeding? Does it actually cross into the breast milk for the baby to still get some of a dose, right? Those are concerns you have to think about. We had one patient, we actually got consulted when I was in my fellowship to the NICU, and it was like, well, when the heck do you ever get a tox consult to the NICU? Well, never, except in this case, they couldn't figure out why this baby was just acting so fussy, and it just didn't seem right? And it turns out the mom had been on SSRIs throughout pregnancy. The baby got put into the NICU because I don't remember why they were in the NICU, but they were in the NICU. They were not exposed to mom. Mom was not having breast milk at that time. Breast milk was getting to the baby, so the baby's effectively going cold turkey. So we said, okay, well, that makes sense. The baby is withdrawing from not having exposure to the Zoloft or whatever that happened to be. And so now we need to manage that, right? Now we don't give them little neonatal doses of Zoloft, but we can give them other things like clonidine or other things to try to help decrease the effects of that withdrawal, okay? So again, these are all things we have to think about here. But any SSRI is going to be fine here. Citalopram, fluoxetine, any of these are going to be totally fine for these patients there. As I mentioned, TCAs can be potentially used, but we don't like them as much. Consider second line. If they fail an SSRI, this might be a decent backup drug. Okay. Now, folic acid, as I mentioned, is super, super important. Now, when's the time to take folic acid when you're pregnant? Well, before you're pregnant, right? If you start taking your prenatals when you get pregnant, it's too late at that point, right? The risk for neural tube defects has already occurred. So you always want to make sure you're taking your prenatals, even if you're not looking to get pregnant. Just take them anyway. It's totally fine. Get that folic acid in, right? Typically, 400 micrograms a day is going to be sufficient for most individuals. And however, if they have a history of a baby with a neural tube defect, they actually recommend upping that by a significant amount, right? So a 10-fold increase in dose to 4 milligrams per day there. Again, is there any downsides of folic acid? No, it's totally fine, right? So again, it's a water-soluble vitamin. If you have any extra, you're just going to pee it right out, okay? Very few women actually follow this recommendation, and again, it's the #1 cause for neural tube defects. Tocolytic therapy. Anyone know tocolytic? So decreasing the contractions, right? So it's tocolytic, so it's stopping the contractions. You're absolutely right. So again, some women are going to have premature contractions. There's some things we can do to try to inhibit that. And again, this is going to be in these cases here where we want to keep the bun in the oven, so to speak, as long as we can. So if it's premature, we want to try to give these tocolytics to stop that from occurring. We have a couple different classes of drugs here. So one, we have beta agonist. So we have a drug called terbutaline, which actually works just like albuterol does, but it's an IV agent or oral agent that actually activates the beta-2 receptors. Now, again, going back to your autonomic nervous system lectures, right? We talked about this stuff. Beta-2 receptors typically do what to smooth muscle? Relax it. Does it on the vasculature, does it in the lungs, does it on the uterus. That makes sense why we give a beta-2 agonist to relax that uterine tissue, right? It's going to relax that muscle there. So that makes good sense. Magnesium, we also mentioned, potentially use. Good for the preeclampsia, but maybe also works to help us relax that smooth muscle. Maybe not used as commonly as the beta blockers, or I'm sorry, the beta agonists here. But the more common thing that I see a lot of patients who are on when they go home for the long term are actually going to be calcium channel blockers. So typically you're going to use a dihydropyridine like nifedipine, and they'll be on that. And again, if they have preeclampsia, this is also good for the blood pressure as well. So this is where nifedipine kind of pulls double duty if you have both of those issues going on there. And again, by stopping the contractions, you're going to be able to keep that baby in there for longer, cook for longer. And what's a full term gestation time? Like 38 to 42 weeks, right? So somewhere around there. So again, if it's coming in, it's like 33 weeks, 34 weeks. Like, you want to stop those contractions early, try to keep them in there as long as you can, okay? And NSAIDs can be used potentially. However, we do know there's some concern, especially in that third trimester with PDA closures and things like that. So that's not used as commonly. Probably the most common thing I've seen, at least, is the nifedipine for that. Other things we can consider is going to be actually administering progesterone. Progesterone will also inhibit these contractions here, and so we actually used to use a custom compounded product here of this 17-alpha-hydroxyprogesterone. It was an IM shot. We'd have to compound it like in specialty pharmacies, and you'd administer, especially to women who had a history of preterm labor. So, for instance, I have a family member who had her first baby at 33 weeks. Premature, and then she got pregnant with twins, and twins likely go early as well, so they were concerned about that, so she actually got put on these progesterone shots. However, guess when the babies were born? Like 33 weeks in the same exact day as like the first one. It's kind of interesting how babies like tend to like go like, this is just the time you're going to spend in the oven, and that's it. And both my kids were born like the same exact like calculated like gestational time. It's very odd the way that works, but anyway, so typically you're going to see this more in high-risk women who've had a history of preterm labor. They're going to receive this. And then actually we have a new medicinal product. It's actually a commercial product is made, but it's a lot more expensive, of course, than the compounded one was. So you may still see some people going to those compound pharmacies for that because it might be a little bit cheaper. Now, let's say we want to do the opposite. Let's say we want to actually get that baby out of there. Say, guess what? I am done. This bun is ready to go. Get it out of here, right? And so this is where it can actually induce labor, and this actually makes sense. So if you recall, we talked about back in our GI lecture, what was something we could give along with NSAIDs to help prevent peptic ulcers? We give misoprostol, right? That was what kind of drug? It's prostaglandin, right? Who do we say you could not use that in? Pregnant women. Why? It's an abortifacient, right? It actually caused induction of labor. So actually, in this case, this is good. We want to use it for this purpose here. And so we have a couple of different agents. We have misoprostol we can use, right? Or we have one called dinoprostone. This one's actually given vaginally. You can actually apply it directly to the cervix, and it will help to ripen it up and get it ready to go from that standpoint. And so you would actually use it. Basically, you'd apply it, and then when the labor's getting ready to start, when you're ready to push, then you actually remove it because then presumably the woman's ready to go, right? However, you have to worry about things like watching for fetal heart rate. You're monitoring that anyway, but again, you could see issues where they get bradycardic potentially due to the prostaglandins there. So just something to note along with that. But any of these two would be totally fine. Misoprostol is an oral product versus Zervidil being a vaginal product. Other things we can use is oxytocin. Now, what does oxytocin normally do? Causes contractions. What else does it do? It's like our feel-good, lovey-dovey sort of hormone, right? So this is what gets released when you, I don't know, like go hug a puppy or something like that, right? So it helps to form that bond between mom and baby and all that good stuff. But it's also very good to help stimulate uterine contractions, right? So a lot of women, especially if they're having more prolonged labor, will get put on oxytocin drip. It's Pitocin. Now keep in mind, is actually one of those look-alike, sound-alike kind of drugs, because Pitocin is the brand name for oxytocin, but there's also a drug called Pitressin is the brand name, and it's actually a brand name for vasopressin, or antidiuretic hormone, so those two you don't want to get mixed up. But oxytocin, really pregnant women, the only people who are going to use this drug for, so it's really kind of relegated just to LND. But this is actually the same product you're going to be producing. And what happens is that normally when you get closer to labor, the uterus starts to upregulate oxytocin receptors anyway. And so again, it gets more sensitive to it, and that's what helps to kind of prolong those, or helps to stimulate those contractions. This is an example of one of those positive feedback loops, right? We're actually going to find this is trying to get something moving, and it's going to go faster and faster and faster until baby's out, right? And so this is one of those cases where the oxytocin is going to help along with that process and going to help to stimulate those contractions in order to actually force the labor along a little bit. Of course, be wary. You can see things like PVCs in these patients due to the oxytocin. There are some risks for bleeding due to this afibrinogenemia. Pretty rare though, right? So again, you're going to find a lot of patients being put on this. Now again, what are we doing as far as like pain control goes for women who are in labor? Epidurals. Why do we use epidurals?
As what level you want, so they could just feel it like breaks down.
Yes, for both of those, right? So one, it limits systemic exposure because I'm applying it directly into the spinal column, so I don't have to worry about it getting elsewhere into the baby. Good. And then also I can get it very specific to where I want it to work at, right? So depending on how the patient is laying, right, the angle they're laying at, the further up the spinal cord it gets, the higher up the drug is going to be working at, right? So if it's relatively low, it's just going to be getting the lower half of the body, versus if it starts to get higher and higher and higher, they may start to feel like, their arms are starting to get affected. That's too much, right? So you need to readjust the patient to where they're not going to have the drug going quite as high. Okay, so it's really kind of interesting how the position of the drug, the position of the patient affects how well the drug is working or where it's working. Really kind of interesting. However, what kind of drugs do we use in those epidurals? We use like a fentanyl, so we use an opioid, and what else? Usually use a local anesthetic, so something like ropivacaine or bupivacaine, right? So just like lidocaine, we have agents that we're going to use here. And so those can be administered, and again, it helps to provide that numbing sort of effect along with the analgesic sort of effect from the opioids there, right? The combination is good. However, when you think about someone who's trying to give labor vaginally, what do you need that woman to do? You need her to push, right? And so one of the things you actually find is that by giving an epidural, it tends to increase the labor duration. Why is that? Because you don't feel it, right? So again, if it doesn't feel super uncomfortable and you're not in a ton of pain, you're not like, oh my gosh, get this thing out of me. You're just like, okay, I feel more comfortable. And so that tends to prolong things a little bit, right? So again, you want the dose to be good where the patient's comfortable, but not too comfortable, right? So that's one of those things where you have to make sure that they are still feeling things. They need to be able to push. They need to be able to coordinate. Because again, if it gets too much, like they can't even move their legs, right? Because again, it's very, very potent at numbing those things, and can be problematic, right? From that standpoint. Again, when my wife received her epidural, I remember I was watching her vital signs, and I saw her heart rate, her blood pressure was dipping a little bit, and I was just like, I don't know, your blood pressure is getting kind of low there. She's like, if you say anything and they turn down this medication, I am going to jump out of this bed and kill you. I was like, well, you can't feel your legs right now, so you're not jumping anywhere. So I just stood at a arm's length, and I was okay. Very limited amount of it actually gets into the systemic circulation, given very small doses, because you're applying it directly to the spinal column. So because it's going into the intrathecal space, there's relatively no exposure to the fetus, which is why we like it so much, right? However, it is, it's a procedure you have to do. You have to get the LP done. Like, it is, you have to think about infection risk. You get spinal headaches, all these things you have to consider there. So just be aware of that. But again, it's a lifesaver because again, labor is very uncomfortable from what I can tell. I've never experienced it, but boy, I do not want to experience it based off what I've seen, right? Anyway, so as I mentioned, fentanyl bupivacaine is the most common combination there. Yes, sir. I don't know specifically. I haven't looked into that. I believe you can't. Yeah, I believe if they don't deliver the placenta, you can administer that to help with that. But yeah, and again, I'm speaking from my perspective, mostly being peds, EMs, I don't see a ton of that. But yeah, if you talk to someone in OB, that probably could speak more to it. But I believe they do. We'll still do that. Yeah. Anyway, so again, adverse effects from the pain medication. Again, think about things like hypotension, pruritus. Oftentimes, you don't even feel you have to go to the bathroom. So most women are going to end up getting a cath put in. So that way they can just pee directly without having to even think about it, which is good. And again, it can cause that prolonged labor there. So something to consider. Okay, so that's it for the OB section. Yes, ma'am.
What do they give pregnant women so that they don't poop on themselves when they're pushing? Nothing.
They just go. So you try to have them go beforehand if you can.
Yeah.
But it's all coming out.
Okay.
Childbirth is not an elegant process. It is not dignified, to say the least. I mean, got like 12 people in the room just playing. I remember for my first child, I remember it was all new to us. We were like still kind of getting used to the process, and they had this mirror. Because when you're getting the epidural, like you're not feeling things as much, so sometimes they'll use a mirror so that way the woman can see what's going on, so that way they can kind of coordinate better. And so it's to kind of aid along with that. And so I saw this big giant mirror there. I was like, oh, we got a mirror so you can check things out. She's like, I do not even want to see anything that's going on down there. And so some people just don't like it, right? But yeah, it is not a very dignified process, right? But it's good to let them know, hey, this is normal, right? So
Yeah.
You're gonna poop on yourself. That's okay. Whatever. We'll clean it up. Nurses are used to that. This is what they've done this a million times. They're gonna do it a million times more. It's totally fine, right? So, anyway. So, any questions on the OB section here? All right. So, getting into talking about estrogens and progestins. I'm gonna tell you the menstrual cycle gets complicated, right? But we're gonna get through it. You guys covered this in your Clin Med course already. Talked about it before. A little bit. Okay. My disclaimer is I barely know how women work. However, I am pretty good with the menstrual cycle. I am pretty familiar with what's going on with these changes here. Doesn't mean I know how to talk to them or not get in trouble with my wife when I say stupid stuff. But anyway, I can at least determine how these things are going on with the list of the hormones go. But looking at this, so this is a negative feedback loop, just like anything else, right? So again, coordinating between the hypothalamus, the pituitary, anterior pituitary, and the ovaries. Okay, we're gonna find here that what are the two main things that are stimulating the ovaries? LH and FSH, right? LH stands for luteinizing hormone, and the FSH, follicle stimulating hormone, right? So again, these are, and in fact, I'm probably not going to get into the same depth that I normally do, like say for instance, like in my physio course. So if you guys were interested, you can go back to my old videos if you want to get a refresher on that stuff. I go much more in depth on all the changes that occur there. I'm going to mainly focus on it from the terms of hormone replacement therapy from postmenopausal women, and then from terms of oral contraception, right? Those are the main things I'm focusing on here for these purposes. So anyway, so what happens during the menstrual cycle? Well, you can see here there's several characteristic changes. Also note here that this is a cycle, right? So again, it's going to occur pretty regularly for the most part. Not everyone has a regular cycle, but you're going to find that typically it's going to be on this kind of 28-day sort of cycle here. And what happens is that you're kind of coordinating between, one, the actual follicle that develops within the ovaries. You're going to be looking at the endometrium within the uterus itself, and then you're going to be looking at the hormone levels that happen here. Okay, so when you have your gonadotropins, there's LH and FSH. You have levels of estradiol and then progesterone. Okay, so what happens here is that usually in the early stages, you're going to find that you have one particular follicle that's going to be developing, right? It's going to kind of take over. And again, what stimulates that follicle? Follicle stimulating hormone, right? So it's right in the name, right? So it's kind of good. Yeah, so we'll get to LH in a second here. But what you notice is that usually FSH is going to be the thing that kind of helps us stimulate the development of that follicle here. So you're going to have one that kind of gets to be the dominant one, right? It turns out that graphene follicle, right? Anyway, and you're going to find it will secrete things like inhibin to try to prevent other follicles from trying to develop at the same time. But generally, you only want one pregnancy at a time, right? Most people can't handle more than that. I can barely handle one, right? Anyway, so you find this follicle to develop here. At the midpoint here, when you actually have ovulation occur, you're going to find that you have what we call the LH surge. And this is where you're going to find a huge jump in LH is going to stimulate that release of that follicle. The ovum, the actual egg is going to be released, and it's going to start to travel down the fallopian tube. Okay. At that point, what you're going to find is that the hormone levels are going to change pretty drastically as well. What you're going to find is that when you start to get this this corpus luteum that develops here afterwards, you're going to find the estradiol is going to start to develop here. It's going to start to be released. So estradiol levels will go up, and then it's going to eventually drop back down, right? So once you have actually the ovulation occurs, estradiol levels start to drop back down, and then you're going to have progesterone kind of peak up towards the later end of the cycle there. Again, this is what is going to be stimulating further changes in the uterus and the endometrium and all that stuff in order to get it developed and get ready to go for implantation. And then if that implantation does not occur, levels are going to drop off pretty precipitously. This corpus luteum turns into like Candida albicans, is going to eventually atrophy off. It's not going to stick around. And so that sudden withdrawal of those hormones, your progesterone and your estrogen dropping off, is what will stimulate sloughing off of that endometrial tissue. And that is when you have menses. Okay, and then the cycle happens all over again. It gets ready for a new pregnancy. If it doesn't occur, the whole thing goes on towards menopause, right? So looking at this, there are several ways we can affect this cycle here, right? So we can either give things to try to supplement it, or we can try to give things to try to shut the whole thing down. Okay, by shutting it down, what does that do for us? It prevents ovulation, right? And it prevents pregnancy. So our oral contraceptives are going to be playing a role here as well, right? And in fact, if you give constant hormones, if you never have that withdrawal, guess what you never have? You never have a period, right? So in fact, there's actually drug products we can give based on how we're administering the estrogen and progesterone. You may find you only have maybe 4 periods a year, maybe only have 1 period a year, all based on how we're actually giving the drugs and exposing it, right? You can retime the period. You can do all kinds of interesting things. I actually had an acquaintance of mine who was having their birthday this weekend, and they were worried about having their period over their birthday weekend. And so we actually talked about ways to actually get around that, right? There's going to be something I'll talk about called honeymooning. You can actually do to modify how you're taking your medication to make sure you don't have your period on the wrong time. Very interesting the things we can do with our hormones, right? So anyway, so as I mentioned, there's a lot of disturbances here that happen with the ovarian. I talk about it's like magic or something. To me, it seems like it's black magic almost. Like, well, we're shifting things around. Like I mean, this stuff that's coordinating with the moon. Like, this is crazy, right? But we can change it through modern medicine. We can modify this stuff. But looking at these disturbances in ovarian function, it's very, very common. We're going to run into this, right? So you're going to find that could be due to inflammatory issues, could have cancerous issues, all kinds of problems that can develop from this. generally you're going to find that most of the disturbances can be more transient, right? So things like having extremes in emotional stress, or if you're not eating, or you think about like young female athletes who are like running marathons or running track, oftentimes they get amenorrheic because, again, if your body's in a state where you're so stressed out that your body thinking, well, we can't get pregnant right now, we're barely surviving on our own, it will disrupt that process itself, right? That's how I kind of think about it. So like I always think about like PA school, like, you know, you guys are going to get peptic ulcers from all the cortisol, and then you know, amenorrhea because you're so stressed out, and like, you know, just all kinds of issues that can pop up from this, just being chronic emotional, physical sort of stress, right? I'm not saying that I've ever had anyone tell me that happened. I just kind of postulate in my mind, like, I can see some of this stuff happen. However, that's where some of your cohort are doing that study, right? Checking your cortisol levels. That was, I think, partly my idea, right? So anyway, that was a joke and someone ran with it, so I was like, all right, go for it. Anyway, so looking at the actual products that we produce ourselves, so we have estrogens, and again, guys, we produce estrogen ourselves as well, right? That's all part of the same physiochemical process here. You're going to find that estradiol is the main estrogen that is formed in women, right? And the majority of the estrogen actually gets formed within the ovaries. You can find it gets produced elsewhere in small amounts, but the ovaries are the main place it's going to be seen there. You can find that the liver is really important for helping to metabolize and convert some of these products as well. And so the liver effects are a big thing we're going to talk about, right? So you're going to see things like cholestasis, you're going to see things like clotting issues. All that's going to be from the effects of these estrogens on the liver, as we'll see in a little bit. But estrone and estriol are also important, but estradiol is the main thing we're going to be focusing on, okay? Now, interestingly, I always like to point out when we have animal products that come in, have a genesis in some of our medicines, we actually used to use for a long time equine estrogens. Equine just meaning horse, right? So we actually used to use, we have these pregnant mares, right? So these female horses are pregnant. They actually produce a ton of estrogen. And where does a lot of estrogen get eliminated? Actually in their urine. So what we used to do is we would take their urine, we collect all the estrogen out of it, and then that was our product we would give to people. So if you ever see pregnant mare urine or Premarin, Premarin is where they get the brand name from. Now we do it synthetically. However, that was the genesis of it, right? So that's where we actually used to actually get it from. So again, if it tastes a little bad though, patients say, it's kind of a urine kind of taste to it. You're like, oh, it's from the horses. Not really, right? Anyway, that's where it used to come from. But just to note that even though the horses are producing a slightly different variety, this equelin and equelinin, there's enough cross-reactivity where it still interacts with our receptors, right? It still has the same sort of effects there. So it's kind of interesting there. And again, some of these can be used for replacement. If you're not producing your own estrogen, some of these are going to be used to help shut the whole system down. We'll talk about how that works in a minute. Now, looking at this process, you can see here that, you know, I didn't get specific into the phases, but there's a follicular phase and a luteal phase as far as the menstrual cycle goes, in determining what sort of hormones are being produced, and then the development of the endometrium and all of that. But one of the things to note here is that you're going to have this kind of common precursor here, this androstenedione, right? And this is a precursor both to testosterone, and if you interact with this enzyme called aromatase, it actually forms estriol, right? So you see estriol, see estradiol here. And so this is important because if you think about it, okay, well, let's say I have a woman who has, say, breast cancer, and that breast cancer is responsive to estrogen. Because one of the things we know that estrogen does is stimulate development of breast tissue. So say they have this cancer, and I wanted to, say, stop the effects of estrogen on those receptors. What could I do? Well, one thing I could do is stop the production of estradiol, okay? I could do that by inhibiting this enzyme aromatase. Okay, great. So I did that. And so what are some side effects you expect to see? Hirsutism. Okay, why would you see hirsutism? Absolutely, right. So again, because I'm stopping this process here, you're going to find a buildup of this androstenedione, and it's going to increase the actual production of testosterone. So what you end up seeing is that when you stop production of estrogen, you're going to see these more masculinizing sort of effects like hirsutism. You can see acne, you can see deepening of the voice, etc., mainly due to the estrogen, the androgen effects.
Did you see more aggression?
Potentially, I think you're going to be feeling pretty crummy anyway. I mean, if you think about the effects of menopause and decrease, because that's essentially what you're doing, right? You're kind of putting them into a menopausal state by decreasing the estrogen. Menopausal women don't feel great anyway, right? So again, who's to say if some of that could be some mild increased aggression from the testosterone? I don't know that anyone's ever really kind of delineated one versus the other necessarily, but they're going to be probably grouchy anyway, just because the side effects of the medication are pretty bad. However, you're treating cancer, right? So again, it's just kind of a plus-minus sort of thing there.
I can't remember. Do men use this too?
No, because men typically are producing very small amounts of the estradiol, where it really is not going to be that big of an effect. You don't really see men taking aromatase inhibitors to try to increase testosterone levels. Yeah, not that I'm aware of. If anyone has, they probably wouldn't get a whole lot of bang for their buck, right? Because we don't have ovaries that produces a ton of estrogen in the first place, right? So again, that's mainly where you're going to see a lot of being produced. We only get estradiol being produced because as kind of a byproduct of this, we don't actually have the corpus luteum that's actually like producing all of that, to speak of. Anyway, so getting into some of the synthetic estrogens, you're going to see commonly ethinyl estradiol is probably the most common one you're going to see. If you look at most birth control products, and actually I need to upload a PDF. There's a PDF I'm going to put up that has this entire like huge page of all the different oral contraceptives that are out there, and I mainly post that to illustrate just there's so many different varieties that are out there, and we'll talk about the monophasic, biphasic. We'll talk about the different varieties that are out there. Most of them though, 95% of them are going to include ethinyl estradiol as your common one. So if you ever see like a birth control and says EE, that's what it stands for. Is the ethinyl estradiol contained in that. Okay, there's other ones we have here as well. Just note that most of these are going to have the same activity, right? They're still going to interact with the same estrogen receptors. And where are those receptors at? We know. They're in the nucleus, right? Because this is affecting just like cortisol, just like hydrocortisone, just like testosterone. They're all getting in the nucleus, actually affecting gene transcription. So again, are these very fast-acting medications? Not necessarily. Right? Take a little bit of time to really kick in there. Okay, and again, that will be important when we talk about how long you give some of these products a trial before you say whether they're working or not for the patient. Okay. And we also have conjugated estrogens. These are basically going to be a mixture of different components, and this is a common one you're going to see used for hormone replacement therapy and menopausal women. Okay, so looking at the kinetics of estrogen, you're going to find that normally it's pretty highly protein bound. Peripherally, it will get converted from estradiol over into estrone and estriol, but clinically, we really care about the estradiol. That's the one we has the most activity there. The important thing I will note here is that it gets conjugated in the liver and then gets eliminated through the bile. So one, you're going to see a lot of metabolic effects on the liver due to this metabolism, the effects that estrogen has on the liver. And you're also going to find that when it gets sent out through the bile, the normal bacteria in the colon are going to actually cleave those, remove the conjugated portions, and then you can actually reabsorb the estrogens. And what would you call that cycle? Remember that enterohepatic recirculation? This is a very good example of that, where you will extend the half-life of things like estradiol when you have this enterohepatic recirculation, right? The same thing goes for your oral contraceptives, any of these estrogen products, the same thing will happen, okay? Which is why there's that concern whenever you say you're taking your oral contraceptives and then you have to get put on a course of antibiotics. What do they tell you? Use a backup form of contraception, because what happens with those antibiotics in the gut bacteria? Kills it off. So the concern is that you're not going to have that, you're disrupting that recirculation of those estrogen, you're decreasing the half-life, and if estrogen levels drop, what could happen? You could ovulate, and then if you ovulate, you could potentially get pregnant. So that is a concern. It is, do we have studies that show that? Can I take 100 women and put 50 of them in the control group and 50 of them in the experimental group and say, sorry, you're pregnant now, it's a side effect of the study? No, you can't do that, right? It's a theoretical concern. However, most people, it's like, well, just use some backup contraception, for the 14 days or the 10 days you're on the antibiotics. Probably not going to be a big deal, right? Again, better play safe than sorry, because again, does anyone, in those cases there, it's a pretty big side effect if you get pregnant on accident.
Wouldn't you want them to continue using double birth control for some time after?
Probably, yeah. I mean, you'd probably say for
their bacteria is not going to come back right away.
Exactly, yeah. So presumably you could be like, maybe take it for like a week or two after. It's just. Again, it's one of those things where it's like we don't know what the right answer is, and we're never probably going to know. So whatever you recommend is probably fine. Even if you said you don't need to use backup, then it's probably fine too, right? Again, we can't really quantify how much of a disruption you're going to have with that. But anyway, so that's what we tell people. But looking at this, we see a lot of hepatic effects, and this is going to be including into a lot of the side effects we're going to see, potentially deadly side effects, because again, estrogens can be deadly in some patients, as we'll see. And it also means that potentially you give this via other routes to avoid a lot of those hepatic effects. So this is cases where you can use like transdermal estrogen. This bypasses a lot of the first pass effects in the liver, right? Because again, how are most of these estrogens given? Usually orally, right? Think about oral contraceptives, think about these hormone replacement products are usually oral. So you're going to see a lot of hepatic effects due to that first pass effect. But by giving things transdermally, by giving things via injection or vaginally, you can limit some of those hepatic effects and try to get more local sort of effects here, right? So again, if I just have a patient who has, say, vaginitis due to menopause, if I just apply an estrogen intravaginally, I get a lot of local action there, and I don't see a lot of systemic effects as well. Now, some of it is going to be absorbed, right? Because the vagina is very a lot of good blood supply. It's very thin membranes. You're going to see absorption, but it's not going to be the same as if you were given like an oral product that is going to get more systemic, right? So once it actually gets into the cells, and again, depending on where it's working, you're going to find different activities, right? So for instance, what does estrogen do in the bone? It inhibits the osteoclast, will stimulate osteoblasts. What does it do in the breast tissue? Makes it, it stimulates hyperplasia of the tissue. So again, depending on the site, you're going to find different actions here. And this is important when we get into what we call the selective estrogen receptor modulators. You're going to find some drugs that actually act as an antagonist in one tissue and an agonist in another tissue. That's important because what happens, say for instance, if I decrease estrogen production in a woman, say on the bones? Osteoporosis, right? That's a big risk with those aromatase inhibitors I mentioned. If you decrease estrogen production, you can see osteoporosis. You can see fractures from that. So this is important to know that estrogen will have different activity depending on the tissue that you're at. And so once it gets into the nucleus, then it can change gene transcription. It will inhibit some proteins from being made. It will stimulate others. And that's where you get your mechanism from. So, and again, as I mentioned, you have different mixtures of these dimers of estrogen receptor alpha, beta, etc. But it just means that in different tissues you get different actions. Okay, so what happens with these estrogens? Well, it will stimulate things like female growth, sexual maturation, right? So you're going to get development of the secondary sex characteristics for these females here. This is where you see a lot of changes in fat distribution, hair growth, and things like that are going to be stimulated by estrogen. And then also the endometrial effects, these are important, will develop the endometrial lining, right? So again, when you're having those first 2 weeks of the menstrual cycle, you're going to be seeing that the endometrium is starting to develop, and that's mainly due to the estrogen there. And why do we want that endometrial tissue developing? Because if you have implantation, that's where the blastocyst is going to be. That's where the placenta is going to develop. You want that there in order to support life, essentially. However, what could happen, say, if I had unchecked exposure of the endometrial tissue to estrogen? Endometrial hyperplasia, which could lead to cancer, right? So again, these are the things you have to consider here. If you have someone, for instance, who has no uterus, I could give an estrogen product by itself, and it's not really a big issue because they don't have any endometrial tissue, right? However, if I have someone who has an intact uterus, you cannot give estrogen by itself because the risk for that hyperplasia and that cancer is too high. So as a caveat, we'll mention here going forward, and when you're selecting what drug products are appropriate for your patient, you have to determine, do they have a uterus or not? Usually pretty easy to determine, right, based on their history. Once you determine that, then you can figure out what you can actually give the patient. And I'll talk about what you need to give it with in just a moment here, okay? Also, this is where you see a lot of abnormal bleeding and whatnot. It's just, again, overdevelopment of that tissue can lead to some of that irregular bleeding that occurs. And we'll talk about how you can modify the dose of estrogen and or the progestin to actually affect bleeding and when it's happening during the cycle there. Other metabolic effects you're going to find that by decreasing bone resorptions has good positive effects on the bone. You're going to find changes, things like lipid profiles is going to help to increase HDL, will decrease total plasma concentrations of cholesterol, all these sorts of things. And again, it goes back to the hepatic effects, right? Because that's where most of your cholesterol is being managed. Stimulation of adipose tissue development, etc. And this is the other big thing, the coagulation effects. So if you ever have, say you're working in the ER, and you have a young woman, say 16, 17, 18, who presents with acute chest pain, what do you want to ask them? Do you take birth control, right? Because what are you ruling out? DVT or PE, right? So again, that's a very common thing because we know these estrogens, again, usually ask, are they on oral contraceptives or are they smoking, right? Or they do the two together, double trouble, right? So what you see is that the oral contraceptives, the estrogen will stimulate hepatic production of clotting factors like 2, 7, 9, and 10, right? Just like warfarin inhibits those, this actually will stimulate production of those. So by having more clotting factors, you put yourself in this hypercoagulable state. Just like we talked about with pregnant women, right? We said pregnant women have high levels of estrogen and progesterone. The estrogen will stimulate clotting factors. So again, if you're having bed rest because you're preeclamptic, and you have all these extra clotting factors, you're likely to get a clot. Same thing can happen to these young women. So if you ever have a young woman who has like no medical history and they come in for a PE, chances are it's either smoking or contraceptives or the combination of the two, right? Other than that, you can decrease anti-thrombin 3, which we know is really important for helping heparin to work, etc. So that's an important thing we'll look at, and that's actually one of the contraindications for use. And then other effects, things like mood, libido. In some patients, you may find that hormones can help with their mood. It may hurt their mood. It just depends on the patient, how they're responding to it. And also other things you're going to find is that because it's a hormone, it can have some cross-reactivity and can affect things like the mineralocorticoid receptors, and that can affect things like edema and fluid retention. Okay. Remember what normally affects the mineralocorticoid receptor? It's our main mineralocorticoid, aldosterone, right? So again, when you have that cross-reactivity and it interacts with that aldosterone receptor a little bit, you can end up seeing fluid retention and that edema that occurs there, right? And again, what's a common complaint of women around their menstrual cycle? Complaint of bloating, right? So again, that's the thing that's due to the fluid retention, okay? some things like started clicking in the sense. You're like, oh, okay, now it makes sense, right? The funny thing is that when I first started teaching this course for PA students, I just assumed like all women just like knew this stuff inherently. Like you're just born with a book that says like, oh, here's how everything works. A lot of people had no idea. I was just like, wow, I'm actually teaching them something about themselves. But anyway, so again, some of this stuff actually has a mechanism to it, right? So again, if you can think logically back to which receptors are being affected, what kind of cross-reactivity am I having, it makes a lot of sense why some of these effects are occurring and why some of the side effects are going to occur as well, as we'll talk about later on. Okay. So when do we use estrogens? Well, oftentimes for primary hypogonadism. So say if someone is not able to produce estrogen themselves, we can replace it, right? So again, this is part of that hormone replacement therapy. And typically what you're going to find is that for those young patients who maybe need that kind of that stimulation, because normally when do estrogen and progesterone levels start to really peak up in a person's life? Usually on puberty, right? So again, this is when you're going to see, 9, 10, 11, 12. Again, if you think about it, like, when do our pregnancy checks kick in over at the children's hospital? What age? We'll check as low as 9, right? So again, if I have a drug that maybe can negatively affect the fetus, they will fire a pregnancy check for a 9-year-old, right? Because some girls will develop puberty at that point, right? So it's just something we know. I think it's really annoying too, because like every single person going to surgery getting Versed pre-op gets a pregnancy check, and I'm just like, oh, yeah, every single time. Like, but again, it's one of the part of that alert fatigue, right? So if you're constantly having to click through alerts, eventually you just stop looking at them, right? You just kind of click through. It happens, right? Everyone. You guys are going to do the same thing too, I can guarantee you. But anyway, so that's something you can see there. But when you're doing this, again, you're trying to mimic the normal cycle. So if you're replacing the hormones, and you're trying to mimic a normal cycle, you're going to do the same thing their body normally would do, and give active hormones, say, through the first 3 weeks, and then you'll have a withdrawal period, right? That last week is when what's going to happen. The actual menses, right? The actual withdrawal bleeding occurs at that point. So typically when you see that, and if you look at a pack of oral contraceptives, what do you notice for the first 3 weeks? They're one color, and then the last week is usually a different color. It's placebo pills. Why do you put placebo pills in there? So you're in the habit, right? You're taking something every single day. It's really hard to say, well, take this for 3 weeks and don't take it for a week, and then make sure you take it again the following week. That's really tough for people to do. So by having that habit of taking something every single day, they stick to that habit, and it helps to reduce the failure rate for those things. Okay? Because our oral contraceptives perfect? No, they're not, right? So they can fail just like anything else in this world can fail. They can too. That's assuming perfect use, right? So if someone's using it at the same time every single day correctly, it still can fail. But anyway, and then at a certain point, once they actually have their first menses, then we'll actually add on progesterone to their system. And again, that will help to mimic what they would naturally be producing as well, right? In that case of primary hypogonadism. I'm probably going to have to cut it here, so I'm going to check the board real quick to see if any questions. Any questions right now? Yes, ma'am.
Next week, right? Is it going to go up to this point?
Yes, it'll cover up to this point. It'll probably go through the OB section if I had to guess, because we haven't really covered a whole lot of like specifics about the drugs here in the GYN section specifically. So let's just say it'll go up through OB.
Okay.
Is that fair? Okay. Now I have it on tape.